Hello everyone. Greetings to everybody in Charterhouse. I am Sneha Mohan, a second-year internal medicine resident, currently in training at the Mayo Clinic in Rochester. And I will be speaking to all of you about osteoporosis today. It would have been wonderful if I could have done this in person, but of course, because of COVID, everything is virtual. But I'm glad that I still have this opportunity. But there's a picture of me down in the corner, so you get an idea of what I look like. So continuing with the presentation. So to begin with, what exactly is osteoporosis? The definition of this can be obtained from the name, where osteo means bone and porosis means something that's porous or spongy. And this is a disease where there is decreased density of the bone, which puts you at an increased risk for fractures. There's another term related to this called osteopenia, which is low bone density, but it's not as severe as osteoporosis. And here is an image representing the transition from normal bone to osteopenia, then osteoporosis. As you can see, in severe osteoporosis, there is more space than actual bone tissue. Next, we have the formal clinical pathologic definition of osteoporosis. And this is defined as a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue, with a consequent increase in bone fragility and susceptibility to fracture. That may seem like a lot, but in a sense, what this definition captures is that every part of the skeletal system is affected, so a systemic skeletal disease. Pathologically, there is low bone mass and deterioration of bone tissue. The clinical consequence of this is bone fragility and susceptibility to fracture. And you can see here in this image an individual with osteoporosis in the femur, which is the hip bone, and the person is sustaining a fracture because of a fall. The key things to note is that the increase in bone fragility and the susceptibility to fracture are the clinically significant features that really define osteoporosis. And here's the reference for the definition. So what is the clinical relevance of osteoporosis? Why do we care about osteoporosis? The main answer to that is fractures. With increasing age, bone density decreases and there is a high risk of fractures with even small, low-impact falls. These can involve virtually every skeletal site. The most commonly affected tend to be the hip, the vertebral column, and the wrist. We see here images of a hip fracture as well as below that, fractures involving the spine. What are the consequences of fractures? This is something that is on the forefront of everybody's mind when there is a fall. Was there a fracture? Was there not? The immediate consequences of fractures include pain in the site of the fracture, loss of function, which could be related to just the bone being broken or because of impact on surrounding nerves and tissue. In the immediate setting, there's usually an ER visit, a clinic visit, maybe hospitalization depending on the extent of the fracture. Perhaps the fracture is too bad that you need to get surgery to correct it. This may be followed by a period of immobilization so that the fracture can heal. And of course, not to mention the cost involving the fracture itself, which includes hospital bills, loss of pay from not being able to go to work, and just social and functional costs because you're unable to do any of your activities of daily living. The long-term benefits could be deformity and disability at the site of the fracture, and maybe this could be leading to loss of employment depending on what your work entailed. Overall, there is a decline in health and increased mortality associated with severe fractures, especially those involving the hip. And we see here an image that represents the consequences of hip fracture after a year following the fracture itself. And we can see here that among all the patients who were studied, a quarter of them died within a year of hip fracture, which is pretty significant mortality. And increasing numbers had disability, inability to walk. 60% had difficulty with at least one essential activity of daily living. and 80% were unable to carry out at least one independent activity of daily living and needed assistance. This is a significant amount of morbidity and a pretty high level of mortality as well. And this is why we're worried about fractures and osteoporosis, which is a risk factor for fractures. Next, let's examine the epidemiology of osteoporosis and fractures. Osteoporosis affects about 200 million individuals worldwide and 54 million individuals in the United States alone. The incidence of osteoporosis and fractures increases with increasing age, with an exponential increase over the age of 80 years. 50% of Americans over the age of 50 years are at risk of an osteoporotic fracture. The graph below represents this in both men and women, showing the incidence of fractures per 100,000 person years. We see that in both men and women, the incidence of spine and hip fractures increases exponentially over the age of 80. The incidence of wrist fracture, which is the pink line shown by Colles, or Colles fracture of the wrist, increases exponentially in women after the age of 80 years. Approximately 3 million hip fractures occur annually, and 50% of these were potentially preventable if osteoporosis was treated. There is also a massive health, wellness, and economic impact of fractures, and estimates have determined that this could reach up to $25.3 billion per year by the year 2025, which is not that far away. Here we have a reference that supports the above data. This slide really encompasses why it is that we need to be vigilant to identify osteoporosis and also provide adequate treatment of this condition. Given the importance of osteoporosis and fractures, how do we define osteoporosis to diagnose it and identify it? The World Health Organization has a diagnostic criteria, and there are two main things which are used to identify osteoporosis. Clinically, the occurrence of a fragility fracture is diagnostic of osteoporosis. And what a fragility fracture means is a fracture occurring from minimal or no trauma, such as fall from standing height, low impact movements, and also silent wedge fractures of the spine, which may be identified on a routine radiograph. In addition to this, testing of bone mineral density, where there is low bone mineral density, is also diagnostic. The way this is measured is by looking at the standard deviation of the bone mineral density as compared to the reference. And the reference here is the peak bone mineral density in healthy young women. And this standard deviation is noted to be a T-score. We will look at this further when we examine how we diagnose osteoporosis clinically and the tools used for it. Below we have a graph that shows the normal distribution of bone mineral density in the population. And if an individual has standard deviation of -1 to -2.5, that would be osteopenia. If the bone mineral density is less than -2.5 standard deviations from the mean, this would be osteoporosis. One major caveat of bone mineral density scanning is that a majority of fractures, especially fragility fractures, occur with bone mineral density values that may be above these thresholds. And that's why we have these two components to really diagnose osteoporosis. Next, I'm going to go over a brief overview of current management practices for osteoporosis. The image here on the right shows the different components. First and foremost, diet and lifestyle. And this includes vitamin D supplementation, calcium supplementation, and physical exercise. We all know that vitamin D is essential for calcium metabolism in the body. It helps to improve calcium absorption, maintain calcium levels in the body, and helps with bone formation. We need appropriate calcium levels as well, which we can obtain through diet as well as medications. Physical exercise is important by providing stress to the bone, which acts as a stimulus for bone formation. Next, we have pharmacologic therapy. These are drugs and medications that can help with improving bone density and preventing fractures. The main mechanisms by which these act is by decreasing bone resorption or bone destruction, and also improve bone formation and bone density. Finally, one of the other components of osteoporosis management is monitoring, which can be done clinically as well as using bone density scans to look at the bone mineral density. I will be going over these different components in detail later in the presentation. Next, I will be discussing several advances in osteoporosis management. We have a lot of data from several cohort studies, as well as epidemiological surveys that have been able to identify additional risk factors for osteoporosis and fractures. All of these have been able to help us develop several risk assessment tools to identify individuals at risk for osteoporosis and fractures to help us prevent fractures by providing therapy. We have been able to develop several novel drugs as well, and along with these several drug regimens have been updated to help us optimize care for our patients while decreasing side effects. We have updated information on screening and monitoring of individuals who are healthy, who may be at risk for osteoporosis, and also for monitoring of individuals who are currently on a drug therapy to help us determine if we need to adjust treatment and also to see how they're responding to therapy. Finally, we have updated evidence regarding benefit from lifestyle measures as well. Over the course of the remaining presentation, I will be incorporating some of the advances in management into the existing knowledge as well, so as to integrate everything to give you a good picture of what you can expect if you were to meet with your primary care doctor and discuss osteoporosis and its management. Let's first look at risk assessment tools. And really, I want to be discussing just the one risk assessment tool, or the FRAX tool. And this is the major one that is used clinically by your primary care doctor or an endocrinologist if you were to visit them to discuss osteoporosis and fracture risk. This is the fracture risk assessment tool. And what this tool does is provide you with a 10-year probability of major osteoporotic fracture. And this is a composite of hip, spine, forearm, or proximal humerus fracture. The tool can also provide you with a 10-year probability of hip fracture alone. Once you get this value, it's plotted on this graph that's shown on the right side. Depending on where you fall on the graph, the next steps of management can be determined. If you're in the green zone, it means that you have low probability of fracture, and just lifestyle modifications would be adequate. If you're in the red zone, this indicates that you would benefit from treatment of osteoporosis to prevent fracture. If you're in the yellow region, additional testing with bone mineral density would be recommended. So how is the score obtained, or what are the risk factors that are looked at to obtain the score? So what are the risk factors for osteoporotic fractures? All of these risk factors are individually used in the FRAX tool to give us the 10-year probability. The first one is a prior osteoporotic fracture. History often repeats itself, and that is why this is an important risk factor. Second is a low body mass index. So if you're low weight, malnourished for your height, that can increase your risk of fractures. Next, we have increasing age with an exponential increase after 80 years of age. This is something we discussed before, and this is something seen in both men and women. The sex does influence osteoporosis risk, with women being at higher risk for osteoporosis and fractures than males. Race plays a role as well, with Caucasians being at highest risk. Family history of fracture is important as well, where there does appear to be a genetic association where individuals whose parents have had an osteoporotic fracture, specifically hip fractures, are at higher risk for fractures themselves. Comorbid diseases, which places higher risk for fractures, specifically rheumatoid arthritis, has been associated with an increased risk of fractures, and the presence of this is included in the FRAX tool. Next, several drugs can increase your risk of osteoporosis, specifically steroids or glucocorticoids such as prednisone, dexamethasone, especially when taken for a long duration of time, can increase your risk for osteoporosis and fractures. Current smoking increases your risk as well. So does alcohol intake of over 3 units per day, and this is about a pint or a can of beer every day. Low bone density, which is something we've discussed before, with a low T-score is something that is included in the FRAX, although this is optional, and you can get a FRAX score even without a bone density scan. Next, let's look at how bone mineral density is measured. This is done using a DEXA scan, or a dual energy X-ray absorptiometry. This is quite a mouthful, which is why we stick to DEXA. Below is a DEXA scanner, where you see an individual lying flat, and the external scanner moves up and down to get a full image of the patient's skeletal structure. What we see here is how a DEXA scan report looks like. On the left is images of the lumbar spine, which is the lower back, and on the right we see both the left and the right hips of the individual. Below you see these pictures that determine if a patient is in the normal osteopenic or osteoporotic range of the bone mineral density. This is determined using the T-score that we discussed before. Osteoporosis is defined by a T-score lower than -2.5, which would put them in the red range. We get different scores for the lumbar spine as well as the hips. If the patient has a T-score less than -2.5 in either the spine or in either of the hips, they would be considered to have osteoporosis. Osteopenia is defined when the T-score is between -1 to -2.5 anywhere in the spine or the hips. And this would be where the individual falls within the yellow range seen in the images above. A DEXA scan is pretty safe. It is non-invasive, as you can see from the image, and the level of radiation is quite low. For reference, the radiation exposure is about 1 to 4 microsieverts, which is a unit of radiation, and when compared to a standard chest X-ray, which is 60 microsieverts, this is pretty minimal. In fact, the background radiation that we're exposed to daily is about 8 microsieverts. So it is extremely safe to get a bone mineral density scan even several times a year if needed, although we do limit this to about every year or every other year, and this would be completely safe for the individual. Using what we just discussed, what are the recommendations to guide clinicians in identifying an individual who's at risk for osteoporosis and fractures? There are recommendations from the UK and the US, but to put it simply, the major overarching recommendations are what I'm going to discuss next. So first, using the FRAX tool. You would calculate the FRAX initially without checking bone mineral density, and this is something that is recommended in all individuals over the age of 50. Depending on what the FRAX tool shows and what the probability of fracture is, you would get a low bone mineral density to screen for low bone mineral density using a DEXA scan. This is also recommended to be done along with the FRAX tool. In the US, it is recommended that all healthy women over the age of 65 years are screened with a DEXA. Also recommended that all healthy men over the age of 70 years are screened, and postmenopausal women with any risk factors over the age of 50 years. Using this framework, every individual who could be at risk for fractures from osteoporosis would be covered. And I would presume that most individuals listening to this talk have had a DEXA scan done over the last few years to identify if they are at risk for osteoporosis and fractures. After assessing if an individual has osteoporosis or an increased risk of fracture, when do you decide to treat? So essentially, you treat when a patient has had an osteoporotic fragility fracture. As you recall, this defines osteoporosis in and of itself. And second, when you have testing that suggests a patient has osteoporosis. So this would be a bone density T-score lower than -2.5, a 10-year probability of major osteoporotic fracture of over 20% per the FRAX, or a 10-year probability of hip fracture over 3% also per FRAX. In all of these settings, you would definitely consider treating osteoporosis with a medication. And a primary care physician may be able to do this, or a specialist such as an endocrinologist could be involved. Other situations where you'd consider treatment would be in women over the age of 65 who have osteopenia, where the T-score is -1 to -2.5. Over here, it is recommended that the individual discusses with his or her physician about the risks and benefits of treatment to optimize their care. Another setting where we would consider treatment is an individual who doesn't fall under any of the previous categories but needs to stay on continuous steroid therapy or hormonal therapy, which increases the risk for osteoporosis. In these settings, usually a specialist is involved and recommends the management of osteoporosis with medications to continue therapy. This brings us to the management of osteoporosis. The first question about management of osteoporosis is really, what is the goal of therapy? And the answer to that is prevention of fractures. There is really no point in managing osteoporosis if we're unable to prevent the occurrence of fractures, given the morbidity and mortality associated with significant fractures. Here I have a repeat of the summary slide of management, which incorporates diet and lifestyle, medication therapy, as well as monitoring. Let's examine each of these individually, also looking at what new evidence we have that supports different management practices. Under diet and lifestyle, let's first examine how vitamin D and calcium supplementation affect osteoporosis and fracture risk. Supplementation do not independently change fracture occurrence. What this means is that giving an individual vitamin D and calcium has not been shown to decrease fracture occurrence in and of itself. However, vitamin D and calcium supplementation has been a part of all the drug trials for osteoporosis management, so there is a benefit when combined with these medications. If an individual is deficient, as found from routine testing, it is recommended that they obtain replacement of vitamin D and calcium. The recommended daily requirement of vitamin D is about 400 to 800 units, and this can be taken as an over-the-counter supplement or prescribed by your physician. Similarly, with calcium, the recommended requirement is 1200 milligrams every day, and this can be obtained from a combination of diet with dairy products and certain other foods like eggs, as well as from medications. The risk of vitamin D and calcium are minimal. However, an individual can have high calcium levels in the blood. This can get passed out in the urine as well, and together these increase the risk of kidney stone formation. Calcium levels and vitamin D levels can be monitored with blood testing, and calcium levels in the urine can also be measured by collecting urine. So these can definitely be examined, and the side effects can be prevented over the long term. The second component of diet and lifestyle is physical activity. Higher levels of physical activity is associated with lower risk of fractures. These are based off of retrospective studies and not randomized control trials. There is evidence, though, that weight, strength training, and resistance exercises do improve bone density in the long run. Aerobic exercises such as running and walking do not increase bone density, but they do preserve bone mass, and so these are recommended as well. Clinical recommendations for individuals would be to do something like yoga, tai chi, weight training to apply stress on the bones to help them grow and remodel so as to improve bone density and strength. Strength training, yoga, we have pictures of that here on the right side. Physical activity is always beneficial, helps with the heart, helps with decreasing other diseases as well, improves musculoskeletal strength, and is also a great way to socialize prior to the COVID pandemic. Now let's move on to pharmacologic therapies, which are drugs that can be used to improve bone density and prevent fractures. Before we jump into discussion about the different drug classes for the management of osteoporosis, I want to briefly go over bone remodeling. And this term really refers to how bone is broken down and reformed over the duration of our lives. I won't be getting too technical, but this does help us understand how the different drugs act. So first I have an image here on the left side that shows how different cells on the surface of the bone help with breakdown of the bone and formation of new bone. It may be counterintuitive to think that bone gets broken down quite often, but this is really essential for the formation of strong bones. Bone that is left unaffected over a long duration of time does get weak. The main cells that are responsible for this are the osteoclast and the osteoblast. The osteoclast is a cell that releases enzymes on the surface of the bone that creates a cavity on the bone surface. This process is called bone resorption. This cavity is essential as the osteoblast, which is the cells that are responsible for bone formation, quickly enter this cavity and release substances to help with bone formation. You really need properly functioning osteoclasts and osteoblasts to help with bone turnover and bone remodeling. Over here on the right side, we look at how all the different drugs and therapeutic approaches affect one or the other process. You have drugs that are either anti-resorptive, that is, they prevent resorption of the bone, or you have drugs that are anabolic, meaning that they help with building of the bone. These are the different methods that I use to help with ultimately preserving bone mass. Now let's look at the medications themselves. This slide is going to be giving a brief overview of the different drug classes. There may be quite a bit here, but we're going to look at all these individual groups separately in the coming slides too. So first we have drugs that reduce bone resorption. These are the bisphosphonates. All of these drugs end with dronate, and that's a way that you can recognize them if you're ever prescribed any of these meds. The second class of drugs is called a rank ligand inhibitor. We can look into the exact mechanism later, but the drug over here is Denosumab, or Prolia, which you may have heard as the commercial name. Next we have anabolic agents which increase bone density, and the two major groups here are parathyroid hormone analog, which is Teriparatide and Abaloparatide. These drugs end with paratide, which is a way you can recognize them. And then we have a new drug group called sclerostin inhibitor, and the drug here is Romosozumab, which was just recently approved by the FDA for osteoporosis management. Finally, we have the older medications, hormone replacement therapy, which is estrogen and progesterone, which are indicated in individuals who are postmenopausal, as well as selective estrogen receptor modulators, or SERMS, which are drugs that act on estrogen receptors differently in different locations, and some of these can help with increasing bone density. Now, over the next couple of slides, we're going to look at all of these different drug classes, their indications, their benefits, and their side effects in further detail. Before getting to the individual drugs, this slide here briefly shows the mechanism of action of different therapies. Starting from right to left, over here on the right we have an osteoclast. Bisphosphonates act on the osteoclast, inhibit osteoclast function, and thereby decrease bone resorption. Denosumab, as you can see here, which is a rank ligand inhibitor, acts on the osteoclast by once again decreasing its activation. Estrogen therapy, the estrogen receptor modulators, act on the osteoblast to increase bone formation. PTH analogs such as Teriparatide and Abaloparatide act similarly. This image did not have sclerostin inhibition highlighted, but we do have a slide that looks at that further too. The first and most important drug class that I'm going to be talking about are the bisphosphonates, and that's because these are the first-line therapy for osteoporosis management. Once an individual has been identified to have osteoporosis or is at increased risk of fractures, these are the drugs that are always recommended and prescribed. The major drugs under this group are over here, summarized over here. So first is alendronate Fosamax. It is something that many of you may be familiar with. This is an oral pill which is taken once weekly. It is the cheapest medication and is the first line recommended by all physicians. Other drugs in this class are Visedronate, which is also oral, given once weekly, but can also be given once monthly. Zoledronic acid or Reclast, which is another commonly prescribed medication, is an IV medication and can be given just once a year. Each dose is expensive, but since it's lower frequency, the cost evens out over time. Another drug in this group is Ibandronate or Boniva, which some of you may have heard. This is also an oral medication given once monthly, but can also be given intravenously every 3 months or so. This is quite expensive. The first three drugs that are listed here, alendronate, risedronate, and zoledronic acid, have been demonstrated in various trials to reduce risk of vertebral, hip, and other fractures. In contrast, ibandronate or Boniva has only been shown to decrease the risk of vertebral fractures. And that's one of the reasons why it's not as frequently prescribed as the other three. But really the most commonly prescribed is Fosamax or alendronate. If an individual is having difficulty with taking this medication orally, they're having side effects from this, then we would consider zoledronic acid or Reclast, as this can be given intravenously and it's only once a year. What are the side effects of bisphosphonates? Given that these are the most frequently prescribed medications for osteoporosis, it is important to keep in mind that there are side effects which need to be balanced out when we're discussing different options for therapy. All the drugs in this drug class are associated with gastrointestinal intolerance, and these are manifested by abdominal discomfort, heartburn. They're generally mild, and if they're tolerated well, they sometimes do get better with time. If there is intolerance noted, alternate medications could be trialed. If someone's having intolerance to alendronate, for example, zoledronic acid can be considered. Another major side effect which is talked about quite frequently is osteonecrosis of the jaw. This sounds really dangerous, and what this means is breakdown of the bone in the jaw leading to severe pain in the jaw. However, over time and over the decades that bisphosphonates have been used, it has been noted that this side effect is extremely rare, and there is really no clinical need to prevent prescription of these medications because of this risk factor. However, it is important to be vigilant, and your physician would be keeping note of this if you were to develop this side effect. Caution is recommended with dental procedures, as this also increases the risk of osteonecrosis. Another abnormal side effect of bisphosphonates is atypical fractures over long duration of therapy. This may seem counterintuitive as these medications are being given for fracture prevention. However, what's been noticed is that when you inhibit bone resorption, you're not going to be forming those strong bones that we had discussed about previously. So the individual who's been taking bisphosphonates for several years is at an increased risk for atypical fractures. However, these are also really rare. Zoledronic acid specifically is associated with unique side effects, and these include flu-like symptoms which can occur during infusion or on the day of infusion. Also on the day of infusion, the individual can experience low calcium levels, and this occurs because the drug is quickly preventing bone resorption, and that keeps in a lot of calcium in the bone, so blood levels of calcium can fall. Another rare side effect that's been reported in some trials is atrial fibrillation, although this hasn't been noted to occur clinically that often. The duration of therapy of bisphosphonates really depends on the agent that is being recommended. For alendronate, a minimum of 5 years of therapy is recommended. For zoledronic acid and reclast, a minimum of 3 years, so 3 injections over 3 years is recommended. The duration of therapy can be extended based off of bone mineral density, which is measured with the DEXA scan towards the end of therapy, or if an individual experiences new fractures while on therapy. After completion of the minimum duration of therapy, and if it is determined that the individual is not at an increased risk of osteoporosis at that time, a drug holiday for 2 to 3 years can be recommended with follow-up bone density scans, with recommendation for reinitiation of therapy if needed. Next, let's talk about Denosumab, or Prolia, which is a commercial name. This is a monoclonal antibody against rank ligand. Rank ligand activates osteoclasts. So you can imagine that inhibiting rank ligand would inhibit osteoclasts, and that way prevent bone resorption. This is administered as a subcutaneous injection every 6 months, so this can be self-administered by an individual. It is quite expensive, but once again, since the dosing is quite infrequent, the cost evens out. Studies have shown that Denosumab administration reduces the risk of hip, vertebral, and other fractures. It's effective against all the different fractures that you could experience. Improved bone density has been noted over monitoring of about 10 years or more. However, this medication cannot be stopped abruptly. Stopping therapy is associated with a risk of decreased bone density and fractures within just a few months of discontinuation of therapy. Therefore, if the medication is planned to be stopped, other medications are to be used to preserve bone density. The side effects of Denosumab are quite similar to the side effects you see with bisphosphonates. Gastrointestinal intolerance is frequently seen. Osteonecrosis of the jaw may be noted, although very rare, similar to bisphosphonates. Once again, caution with dental procedures is recommended. And there is an atypical fracture risk, although this is not associated with duration of therapy as seen with bisphosphonates. There is in addition a theoretical risk of infection and rash, although this has not been clinically noted. The next drug group that we'll be talking about are the parathyroid hormone receptor agonists, Teriparatide or FORTEO, and Abaloparatide or TYMLOS. These are anabolic agents which increase bone mineral density. These are administered as a daily subcutaneous injection, and they can be self-administered. They are relatively more expensive than the other medications, and insurance coverage can be a little difficult to obtain. Trials have shown that both of them reduce vertebral fractures, but there's not enough data to suggest that there is a significant reduction in hip fractures as well. The recommended duration of therapy is about 2 years, followed by the administration of bisphosphonates or Denosumab to preserve bone density. The side effects of these agents are high blood calcium, calcium in the urine, kidney damage from the calcium in the urine, as well as a noted risk for osteosarcoma or bone cancer in animal models. This hasn't been noted in humans, however, a previous history of skeletal malignancy is a contraindication for these agents. Next, let's look at hormonal therapies and selective estrogen receptor modifying agents. These are indicated primarily in postmenopausal women. The hormonal therapy are estrogen and progesterone replacement, and the SERM that is recommended is raloxifene. This is primarily recommended in younger postmenopausal women and can reduce incidence of breast cancer as well if this is something that they are interested in. There is a moderate benefit in preventing vertebral fractures, not enough data for the other fractures. There are several side effects, and these are the side effects that are seen with hormonal therapy in general, which are cardiovascular disease and myocardial infarction, blood clots in the veins, as well as hot flashes that can be seen with administration of raloxifene. These medications can be considered when alternate therapies are not appropriate, but they are not first-line therapy. Finally, we come to Romosozumab, commercial name EVENITY. This is the nucleate on the block, and this is a monoclonal antibody against sclerostin. This drug reduces bone resorption and increases bone formation, combining the effects of all the drugs that we've previously discussed. So the effect of this is a large increase in bone mineral density. This is also administered as a subcutaneous injection, administered monthly, and the duration of therapy that has been recommended right now is 12 months. It is very expensive, as would be expected considering it's the newest medication. Studies have shown reduction in vertebral spine fractures, but not enough data for hip fractures at the moment, although it is recommended for reducing all fractures. After completion of therapy for 12 months, bone density can decrease, so it requires follow-up with bisphosphonate or denosumab therapy. Side effects that have been noted so far include headaches and cardiovascular disease. That concluded our discussion about the various drugs used in osteoporosis. Next, let's look at how this therapy is monitored. Your primary care physician is usually involved in monitoring in coordination with an endocrinologist if required. DEXA scans are frequently performed. These are low risk. However, they're not recommended to be performed within the first 5 years of treatment. The reason for this is that variable changes are noted, and fracture risk is reduced independent of changes in bone mineral density, meaning that just being on therapy can decrease your fracture risk even if your bone density hasn't demonstrated any increase. Bone density can be tested towards the end of therapy to determine the duration of treatment, and this has been discussed with bisphosphonate therapy. If you were to have a fracture during therapy, it is recommended that you get assessed clinically and get a DEXA scan. Therapy may be changed if the bone density is been noted to fall on DEXA, but by this time, usually a specialist, an endocrinologist is usually involved, and they can help discuss if alternate therapy is needed or if there's any other modality that should be considered. So that brings me to the end of my presentation. I'd like to quickly summarize the things that we discussed today. Osteoporosis is a major public health problem because of how it leads to fractures. Fractures themselves place massive burden on an individual's health, well-being, functional status, not to mention increase in mortality and overall morbidity as well. A major risk factor for osteoporosis is increasing age, which is inevitable, and therefore everyone is at risk for osteoporosis and fractures at some point in their life. So it is important to screen and identify individuals at risk early. This can be done using the Fracture Risk Assessment tool or the FRAX tool, as well as a DEXA scan for bone mineral density. These are tools that we discussed in detail, and hopefully this was able to help you identify how to interpret your own tests when you get them. Finally, we looked at management of osteoporosis and fracture risk with medications and lifestyle. This management is usually guided by your primary care provider with the help of an endocrinologist if it has been required. I hope that this was beneficial to all of you and has provided you with a lot of resources to help you understand your care better. There are bound to be questions which you can ask your primary care provider, and if you have any questions about this presentation and you'd like to reach out to me, I have my email in the final slide. Thank you for your time, and I'm glad to have had the opportunity to speak about osteoporosis with all of you. I do wish that it could have been in person, but it's been great that we've been able to continue with this lecture series this year as well. Wishing all of you a great day and a wonderful week ahead. Take care. Thanks.